question is for Dr. Tone. For the patient that you showed with the FOXP3 positive, I noticed that he or she had high levels. Did other patients have similar levels of FOXP3?
Yeah, that's a good question. That I show you just the highest one.
Okay.
To give you that some impression. But that's, we analyze that all patient, but so variable. And then FOXP3 gene expression is actually increase depend on tumor stage, cancer stage. And higher stage that express more FOXP3. And we analyze FOXP3 gene expression in all tumors, but that's, at this moment we haven't compared with the tumor stage and the FOXP3 gene expression. So that's the reason I just show you just only one patient. But later that maybe you analyzing FOXP3 gene expression and then compare with some tumor stage, and then probably we can have some answer, or accurate answer.
I have a question for Dr. Landani. Is there any histologic correlation to any of the genetic changes? Do you see them more frequently in any type of subtype of mesothelioma? There's some rare subtypes of mesothelioma have those been tested at all?
Well,
like lymphohistiocytoid and desiduoid?
yeah, I don't think there were any. Well, there weren't any of those in the DCGA set. We did not see a distinctive histology of those near haploid cases. Otherwise, of course, it's known that sarcomatoid cases have a higher incidence of P16 deletions. And of course, I mentioned the pattern of VISTA expression, which is also different, being higher in epithelioid cases.
You think there is any time now or in the near future that we should be genetically testing these tumors regularly?
Well, I think I'm biased, so I think yes, we should be testing them regularly. But it's true that it's not like testing lung cancer where you actually find, targets.
Targetable lesions.
I think at this point, the immediate clinical benefit is still not there, but I think ultimately we will want to know exactly what we're treating in every case at the genetic level. So.
Okay, Dr. Blythe.
Mark, it's a question Yeah, is that on? So the genome seems to be characterised by a loss of tumour suppressors without oncogenes that could be drugged, and so that's, the low mutation burden makes you feel a bit positive that this is maybe a cancer that we can treat. But how do you know how we might go about drugging these loss of tumour suppressors, and how the cancer develops if it's just loss of tumour suppressors alone without a driving series of mutations that promote the tumour?
I think it's a good question in the sense that at the genetic level we're missing alterations that are activating mitogenic signaling, like MAP kinase pathway activation. I think what's going on is there is at least at the transcriptional level overexpression of a lot of RTKs. And we've looked at that, and others have as well. So there is MAP kinase signaling. It does not seem to have like a genetic basis. I think what people are looking for are vulnerabilities that are secondarily created by these losses. And we haven't yet found the vulnerability for BAP1 loss. There was some thinking that EZH2 inhibition might be interesting, but I think it hasn't quite panned out as expected. So people are still looking for vulnerabilities created by BAP1 loss. There is the vulnerability created by the P16 deletion and associated MTAP deletion, and which extends to interferon, the interferon gamma locus. So, and then in terms of immunotherapy, as a low tumor burden cancer, it's, you know, it presents an additional challenge. So it will either depend, we don't know what targeting VISTA is going to give, and for existing immunotherapy approaches, I think it's probably going to require more sophisticated tweaking to render them more immunogenic. I think we've heard some approaches already today.
And just a quick follow-up. In the TCGA more broadly, are there other cancers that are similarly dominated by loss of tumour suppressors with this same pattern that you're seeing in meso?
Yeah, off the top of my head, I can't think of one that's quite as you know, consistently characterized by losses instead of gains, instead of amplifications. Yeah, so it's quite distinctive.
You else have questions? Yeah.
This is for Dr. Boisgiro. So given that most of us get the MMR vaccine as children and have immunity to measles, is there a chance that the patients would just get rid of the virus before it reaches the tumor?
So that's a classical question. Especially with measles. What they saw in the phase 1 trials, especially for ovarian cancer, it was the patients that were vaccinated. They had patient. The first trial they did is in patients with no vaccination because they were not sure what would happen. But then they found that in another study that actually it doesn't matter. For the TVEC phase 3 trial, they showed that half the patients were seropositive, half were seronegative for HSV, and it made no difference for the clinical benefit. Still, for TVEC, it was intratumor injection, and it's true that if you want to go to systemic injection, or maybe for mesothelioma, intrapleural injection or peritoneal injection, maybe it could be a problem. What people think is that maybe ultimately the idea would be to go with one virus, measles, for example, encoding a tumor antigen, and then you come with a second virus, HSV, encoding the same tumor antigen, for example. And so you can, if you have several oncolytic viruses available for the clinic, maybe you can just go in sequence with different viruses. So far, apparently it doesn't impair the activity, but usually, I think for measles with myeloma, I showed you it was a high dose of virus, but they came with one dose. So you don't know if you need a second dose, will it work? I mean, it's still to be defined, I think.
Yeah. I have another question. When you were talking, you were kind of stressing a lot about the rapidity of the killing, and so you were trying to develop potentially a virus that killed faster, but with less replication. So, is the killing of the native virus a problem? Is it too slow, or is it not enough to take on all the tumor cells, or is that an issue?
I don't know. Measles is pretty slow at killing compared to others. VSV or vaccinia, herpes virus kill really fast. So measles was really slow and we wanted to accelerate. But I'm not sure if that's exactly the right strategy always.
Yeah.
I'm thinking that if you just kill the right way and educate the immune system, maybe it will be enough. But of
Yeah.
course, like if you imagine only virotherapy as a single strategy, yeah, you want to debulk the tumor. But I'm not sure this will happen. You will always have surgery before stuff. So I don't know if the rapidity of killing is that important always. I don't know.
Is there anybody looking at intrapleural administration of oncolytic viruses in a perioperative way that you know of?
I don't know. I don't know what they did actually in the phase 1 trial at Mayo Clinic. If it was, I don't think it was perioperative.
I don't think I don't know of one. Yeah.
I want to ask you about viral specificity because CD46 is a complement regulatory protein.
Yeah.
And normal expression level is maybe low, but it's also expressing normal cell expressing this molecule. Then maybe that's viral also going to normal cell as well.
Yeah.
Then what's happening?
So what we saw actually, we have results. So I told you at first you were thought that you had less CD46 and the less entry of the virus. Actually, what we saw is that the virus always enters, even in healthy cells. It just won't replicate. Because the type 1 interferon response is so efficient, especially against this attenuated measles virus, that few cells will be infected and then produce a lot of interferon that will protect the surrounding tissue, except tumor cells, because usually they have the pathway broken. So that's